Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 15U, which is Hematology, Erythrocytic Diseases, and we are streaming live from the iconic IPGMER Kolkata. And today's topic is something very basic but very important, which is hypersplenism and hyposplenism. And to talk on that, we have Dr. Aniket Halder. He is an MBBS MD Path Gold Medalist and a D.N.B in Pathology. He is an assistant professor in the Gastro-Intestinal and Liver Pathology Unit of the School of Digestive and Liver Diseases, IPGMER, Kolkata. He's got more than 25 publications in national and international journals with areas of interest in GI pathology, liver pathology, breast pathology, and cytopathology. He has been the thesis co-guides of postgraduates and postdoctoral trainees at IPGMER with ongoing project under the WBDSTBT titled Study of Interstitial Cells of Cajal in Chronic Constipation in Children of 2 years duration. He's got contributions in various books, one of them being the textbook of pathology for MBBS by Dr. A.K. Mandal and Shramana Choudhury. Before I ask Dr. Halder to start, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Aniket, sir, please share your screen and let us start. Just press that arrow there
Yeah.
and present now your entire screen. Click in the center and share.
Is it visible, sir?
Yeah, please make it full screen. Yeah.
Yeah. So, okay, it's fine. Is it visible?
Yeah, it's good to go. Please start. Thank you.
Yeah. Thank you, sir, for your introduction. So, today's topic on which I will be talking is hypersplenism and hyposplenism. It is a very basic topic, but all the residents of pathology should have a clear understanding of the function of the spleen and the different aspects of hypersplenism and hyposplenism. So, today in this talk, I will give the basic outline of this talk will be on the basic anatomy and function of the spleen, splenomegaly and its causes, the aspect of hypersplenism, which is the hyperfunctioning of the spleen with its causes, approach, and management. The treatment of hypersplenism, the cases where the conditions where splenectomy is required and its implications, and finally on hyposplenism, its causes, approach, and management. So, starting with the basics, the spleen is the largest lymphoid organ of the body. It is a secondary lymphoid organ, just like the lymph node, and it is an intraperitoneal organ, also known as the organ of Orts. Uh, its size is approximately 1 into 3 into 5 inches. Approximate weight is 250 to 300 grams, which is around 7 ounces, and it's located between the 9th to 11th ribs. And it's derived from the mesoderm. It has a very important role in hematopoiesis in the intrauterine life, where along with the liver, it is the principal organ of hematopoiesis from 3rd to 7th month of intrauterine life. So going to the anatomy of the spleen receives its blood supply from the splenic artery. So the splenic artery, when it goes into the spleen, it enters the spleen through the hilum, and it branches into the trabecular artery. And the terminal branches of the trabecular artery, as they enter into the splenic parenchyma, along with the trabecular artery branches, there is a coaxial length of a lymphoid sheath that covers these arteries as it enters into the spleen. This is known as the periarteriolar lymphatic sheath, which is the lymphoid cells, mainly T cells, which are rich in the periarterial areas. And along with them, in the periphery, there are some follicles and nodules of the B cells. So these B cells are present in the follicles, and just outside the follicles, there is the marginal zone. And this marginal zone, along with the follicle and the periarterial lymphoid sheath, they form what is called the white pulp. And the central, the trabecular artery branch, which enters into the spleen, it then branches and divides into central arteriole, which goes into the red pulp. So this red pulp, it's composed of the splenic cords and the venous sinuses. So a cross section through this white pulp, and through this red pulp we can see this is the central arteriole in the right hand figure, and around this central arteriole, this greenish light green area is the periarterial lymphatic sheath reaching the T cells, and there are these lymphoid follicles, these blue areas just at the periphery, and outside this B cell zone is the this marginal zone, and outside the marginal zone is the perifollicular area. So this is what constitutes the white pulp, and the red pulp it forms the reticuloendothelial system of the spleen. This terminal branch of the central arteriole, when it enters into the spleen parenchyma, the blood flow through the central arteriole can take two paths. It can either enter into an open circulation and open system, that is, can directly flow into the splenic cords, and 90% of the blood it enters through the splenic arteriole, central arteriole, into the splenic cords, and only less than 10% of the blood it enters into the splenic veins, which are the venous sinusoids. So what happens to this blood which enters into this open system, that is into the splenic cords? These RBCs, they have to enter back into this circulation through the fenestrated intercapillary areas, as we can see in this figure. And these splenic cords, or the cords of Billroth, they are nothing but the reticular connective tissue area, which is composed mainly of the fibroblast and the specialized macrophages and some amounts of B cells. So in the spleen, most of the blood that enters into the spleen, that has to enter into the splenic cord, and then they have to return and enter into the splenic sinuses through the fenestrals. So this forms the reticuloendothelial system of the spleen. So the microcirculation of the red pulp, we have open system, which is a slow transit system, and 90%, 80 to 90% of the blood enters into the open system, that is into the splenic cords, and less than 20%, around 10% of the blood has a rapid transit to the closed system, in which the branches of the central arteriole, they directly communicate with the venous sinuses through the capillaries. The spleen flow rate is about 5% of the blood volume. That is, assuming a person to have 5 liters of total blood volume, around 250 ml of blood enters into the spleen per minute. So in 20 minutes, the entire blood has a circulation through the spleen. So we can understand that the blood has repeated passages through the spleen, and so the blood has to undergo this splenic surveillance multiple times a day. And there is a process called the plasma skimming. What is plasma skimming? Plasma skimming is the method, as I had said, in the open system, the blood directly enters into this open system, into the splenic cords. So the blood has different components, but by the process of plasma skimming, the red cells, which are more denser, they usually are present in the axial stream, and this through this axial stream, they directly end up going into the red pulp, whereas the components which are present in the periphery of the stream, that is mainly the leukocytes and the plasma and the macrophages or the dendritic cells or all these are present in the periphery, and they directly go into the white pulp, which is present at the lateral parts. So in the spleen, about 25% of the whole of the T cells of the body, they are present in the spleen, whereas 10 to 15% of B cells, they are present in the spleen itself. As I had said, the T cells are mainly present at the periarterial lymphatic sheath, whereas the B cells, they are present in the follicles, which are just at the periphery of this lymphatic sheath. The marginal zone, this marginal zone is the place which bridges between the white pulp and the red pulp, and this marginal zone, this is the very specialized zone, which is very important, and that I will discuss. And this marginal zone is composed mainly of the macrophages, the dendritic cells, and the B cells, the specialized B cells, which are also known as the IgM marginal zone B cells. These macrophages and the IgM positive B cells, these B cells are these cells of the marginal zone, they are mainly involved in the innate immune system and the innate immunity that the spleen has to offer. And this this aspect is very important for protection of our protection towards infections by encapsulated organisms. That I will discuss in the next slides. So, just recapitulation of the functions of the spleen. First is the filtration function, that is the quality control of the red cells. The spleen, as I had said, it is a huge reservoir of the blood components, and there is pooling of platelets, WBCs and RBCs in the spleen. It has protective and immunological function, and it has extramedullary hematopoiesis is an important function of the spleen. Although in normal individuals it is not prominent, but in diseases where there is ineffective erythropoiesis, the spleen may take up the function of hematopoiesis and may try to compensate the disease conditions. And spleen has an important function in the iron metabolism, because the senescent RBCs, the senescent and the damaged RBCs, they are taken up by the macrophages. The hemoglobin of these RBCs, they are broken down into heme and globin. This heme, this is picked up by the macrophages. They can be stored in the form of ferritin or hemocyanin, or they can be sent back to the bone marrow for utilization during the formation of new blood cells. So, going to the functions one by one, the first most important function of the spleen is ensuring the quality control of the RBCs. So, when the red cells, they pass through the open system of the splenic cords, the RBCs get sequestered in the spleen. They stay there for some time, and they have to enter into the venous sinusoids through the fenestrated endothelial cells. So, what happens is that as these cells are sequestered in the spleen, they will undergo oxidative damage, and there will be oxidative stress to the cells. So the these damaged cells, they will be unable to enter into these fenestrated capillaries, and so they will be phagocytosed by the macrophages which are present in the reticulum of the splenic cords. Also, the antibody and the complement coated red cells which enter into the splenic cords, they are also picked up by the macrophages and are killed there. So, the important function of the spleen is the culling of this of the red cells, which is nothing but the destruction of the aged and deformed RBCs. And there is another function of the important function of the spleen, that is pitting. Pitting means the removal of red cell inclusions in the spleen. So this is a figure, a schematic diagram how pitting occurs. The red cells usually they have a biconcave shape, and they are very flexible. They enter into the venous sinuses through the fenestrations, but the part of the RBCs which contains the inclusions, they are trapped because they are more denser, and they are not easily flexible, and they are more rigid, and they are trapped in these fenestrations, and the sinus macrophages, they pick up and they engulf these pitted parts and remove them from the remove them from the RBCs, and these RBCs, they then enter into the circulation through the venous sinusoids. So another important function is the reservoir function of the spleen. That is, the spleen contains about 5% of the circulating RBCs, but in certain cases in which the spleen is enlarged, there can be up to 40% red cell sequestration in the spleen. So the red cell can be pooled in the spleen, and this is variable. This can be decreased in different infiltrative diseases, and in different congestive diseases like portal hypertension due to cirrhosis, this will be increased. So this is an important function of the spleen. About 30 to 50% of our WBCs are present in the spleen, and this is called the marginal pool of the WBCs. In cases of splenic enlargement, there can be pooling of the WBCs. About 80% of the WBCs may be pooled in the spleen, and this can cause peripheral cytopenias in cases of different cases of splenomegaly associated with hypersplenism, that I will discuss later. And also another important function is the reservoir function of platelets. The spleen is the main reservoir of platelets. About 1/3 of the lifespan of the platelets is spent in the spleen, and about 30% of platelets are stored in the spleen. in normal individuals. Whereas in cases of splenomegaly, about 90 spleen may sequester about 90% of the total platelet pool. So in cases of splenomegaly, there can be significant thrombocytopenia, and this is mainly due to the excessive pooling of the blood in the spleen. Now, coming to the protective and immunological function of the spleen, it is to be remembered that the spleen is involved both in the innate and adaptive immune responses. Now, like the lymph nodes, which are the another secondary lymphoid organs, the lymph nodes are mainly involved in the adaptive immune responses through this. That is mainly through the CD4 plus T cells. And why the lymph nodes are mainly involved in the adaptive immune responses? Because the flow to the lymph node is through the lymphatic system, whereas the systemic blood and the hematogenous uh, the flow of the uh, different pathogens to the spleen is through the hematogenous route. So all the bloodborne pathogens, they enter into the spleen, and main components of the innate immune system are the macrophages and the marginal zone B cells. As I had said earlier, that the marginal zone B cells and the macrophages present in the marginal zone, they are involved in the innate immune system, which is the primary immune component or the barrier immunity. So how the macrophages are involved in the innate immune system? The macrophages present in the marginal zones have specific receptors, which are called the pattern recognition receptors. These pattern recognition receptors can identify different molecular patterns, which are known as pathogen associated molecular patterns, PAMs, or the damage associated molecular patterns, that is the DAMs. So these pattern recognition receptors, they are the toll-like receptors, and other forms of receptors like the nod-like receptors, C-type lectin receptors, and the rig-like receptors. So these receptors are present in the macrophages or in the marginal zone. So when the blood-borne pathogens, they enter into the spleen, uh, these macrophages, they directly identify these different PAMs on the present on these different blood-borne pathogens and directly phagocytose and kill these organisms. Also, the marginal zone B cells, the B cells that is present in the marginal zone, they are specified low affinity. They are low affinity IgM producing B cells, which can identify the different lipopolysaccharide molecules present in encapsulated organisms through the T cell independent pathway without involving the helper T cells. So these two mechanisms are mainly involved in protection. Sorry, in protection towards the against the encapsulated organisms. Also, the B cells which are present in the follicles, they are mainly involved in producing different immunoglobulins, mainly the IgGs, and this is done mainly in relation with the CD4 T cells, which are present in the periarterial lymphatic sheath. These B cells get matured, and through the T cell dependent pathway, they undergo clonal expansion within the follicles, and they also undergo different processes like the antigen class switching and antibody class switching, and they produce the antibodies by differentiating into the plasma cells. The spleen also has important functions in production of different complement components like the propardin, which activates complement through the alternative pathway, and molecules like tuftin. This tuftin is involved in stimulating the neutrophils for phagocytosis, and it also stimulates the production of interleukin 1. So these are the protective and immunological function of the spleen. So just an overview of what I have said. The spleen is composed of a white pulp, a red pulp, and a marginal zone, which is just in between the red pulp and the white pulp. The red pulp is composed of the T cells in the periarterial lymphatic sheath of the follicles, which are rich in B cells, and the periarterial lymphatic sheath, which is rich in the T cells, mainly the CD4 T cells. And the splenic red pulp is composed of the splenic sinuses and the splenic cords, and they are mainly involved in the function of blood filter, that is the pitting and culling of the cells. And this marginal zone, this is the very important zone which is unique to the spleen, which is composed of the B cells, specialized B cells called the marginal zone B cells, the macrophages, and they are the first line defense against the different organisms, mainly the pathogens which have lipopolysaccharide capsules or the sugar, or have sugar moieties in their capsules. And this marginal zone, this bridges the gap between the white pulp and the red pulp. So now, if we move on, now moving to the topic proper, we will discuss these different splenic disorders. So the splenic disorders can be anatomical and it can be functional. So anatomical defect is splenomegaly, which is enlargement of the spleen, and functional disorders, it can be hypersplenism, that is the hyperactivity of the spleen. It can be hyposplenism, where there is decreased activity of the spleen, or it can be asplenia, where there can be an anatomical absence or a functional absence of the entire splenic function. So we are more concerned with the functional defects rather than the anatomical alterations in the spleen. And it should be borne in mind that splenomegaly is not equivalent to hypersplenism, because there are different conditions in which the spleen may be enlarged, but there may not be any significant hyperactivity of the spleen, or there can be cases where the spleen can be enlarged, but there are features of hyposplenism. So hypersplenism or hyposplenism is not equivalent to splenomegaly. So, what is splenomegaly? Per se, it is the enlargement of the spleen, and the spleen size and palpability, they are not equivalent. For example, in case of wandering spleen, which is nothing but a lax phrenicopolic ligament, in which due to this lax ligament, the spleen, it may come down from its normal anatomical position and can be palpable, and it is also highly mobile. So a palpable spleen is not always reproducible with increased spleen size. So spleen size, also the spleen size is not a really reliable indicator of splenic function, as I had said already. So splenomegaly, we can assess splenomegaly by clinically, in which we measure the size of the spleen below the left costal margin. It can be enlarged mild when it is 1 to 3 centimeter, and it is massive when it is more than 8 centimeter, and usually crosses the midline and umbilicus. But more actual assessment of this splenic enlargement can be done on a CT or a USG, where less than 13 centimeter is considered to be normal, whereas a craniocaudal length of more than 20 centimeter should be considered massive splenomegaly, and the post dissection mass, if it is more than 1 kg, it is usually associated with massive splenomegaly. So the causes of splenomegaly, we can classify splenomegaly depending on the different mechanism. So the first mechanism is the congestive cause, in which due to different organ failure like cirrhosis, where there can be portal hypertension and congestion of the spleen, or a right heart failure, which will cause splenomegaly. There can be obstruction due to portal, hepatic, or splenic vein thrombosis, obstruction due to cystosomiasis, because cystosomiasis may cause portal vein thrombosis and obstruct the portal vein, and can cause splenomegaly. The splenomegaly can also be due to work hypertrophy. This work hypertrophy can be due to immune hyperplasia, which is seen in different chronic infections and chronic inflammation, where there is increase in the white pulp of the spleen, and this can be due to different viral, bacterial, or parasitic infections. It can be also associated with chronic inflammation like sarcoid, like SLE, rheumatoid arthritis, or in different lymphohistiocytosis. And this work hypertrophy, that is the increase in the hypertrophy of the red pulp, it can be either due to erythrocyte sequestration, which can be seen in different types of hemolytic anemias, It can be seen in sickle cell disease. Sickle cell disease, usually in sickle cell disease we get a atrophic spleen, or there can be autosplenectomy. But in the early phases of sickle cell disease, we can often have a increased spleen size, and this can be fatal in many cases, where there can be acute sequestration and pooling of the red cells, causing hypovolemic shock. So that I will discuss later. So, in very early phases of sickle cell disease, we can also have mm, splenomegaly due to acute erythrocyte sequestration, and the splenomegaly uh, due to extramedullary hematopoiesis, which is again seen in different hemolytic anemias to compensate for the ineffective erythropoiesis, in myelofibrosis due to infiltration by tumors, uh, leukemias, or due to radiations. And lastly, the other causes of splenomegaly can be infiltration by the different which can be malignant or non-malignant. Non-malignant causes can be metabolic, that is infiltration by uh, Gaucher by the Gaucher cells, Niemann-Pick disease, glycogen storage disease, or can be malignant infiltration due to infiltration by leukemias, lymphomas, metastatic tumors, which increases the vascular bed of the skin, and which increases the overall reticulum and the vascular bed, and hence causes splenomegaly. So there are some causes which can cause massive splenomegaly. Some conditions like myeloproliferative neoplasms, lymphomas, uh, different infections like malaria and Kala-Azar, they can cause tropical splenomegaly syndromes with massive splenomegaly. This is mainly due to uh, the activation of the white pulp. This can also be due to the this can also be due to the activation of the macrophages in the spleen, and extramedullary hematopoiesis. As I had said, in thalassemias, there can be extramedullary hematopoiesis causing massive splenomegaly, and different infiltrative disorders. Most notably in Gaucher disease, there can be massive splenomegaly. So now coming to our topic proper, that is the functional disorder, that is hypersplenism. So what is hypersplenism? Hypersplenism is nothing but hyperfunctioning of the spleen or hyperactive spleen. This was introduced by Schoffert in 1907, and it's not a clinical syndrome, and does not imply a specific causal mechanism. In most cases, it is a secondary to some certain primary etiologies. And the features of hypersplenism is splenomegaly. There should be splenomegaly along with cytopenia. These cytopenias can be monocytopenia, unicytopenia, or there can be pancytopenia. And usually on bone marrow, although bone marrow is not routinely done for confirmation of hypersplenism, but the bone marrow, it will be normocellular to hypercellular, and the final confirmation of hypersplenism will be the response to splenectomy. So if we classify hypersplenism, as I had said, hypersplenism is most often secondary due to some primary etiologies like infections, alcoholism, portal hypertension, uh, defined hemolytic anemias, or infiltrative diseases, storage diseases, in granulomatous inflammations. So in 90% of the cases, it's secondary. Less than 10% cases, it can be primary. The etiology is unknown, and there can be primary splenic hyperplasia, or the other term, that is the non-specific, the non-cirrhotic portal fibrosis, or Punty syndrome, where there can be idiopathic portal hypertension along with hypersplenism. And there is a third entity called occult hypersplenism, which is clinically not relevant, because in occult hypersplenism, it is defined by hypersplenism, which is usually compensated by bone marrow hyperplasia. So there will not be any peripheral cytopenias, and hence it will not be manifested, and so it's clinically not relevant. Now, pathogenesis of hypersplenism. The pathogenesis of a hyperactive spleen is due to splenomegaly, and this splenomegaly will cause increased sequestration of the blood components in the spleen, and this increased retention of the spleen will cause peripheral cytopenias. So this is one cause of pathogenesis of hypersplenism. The other pathology behind hypersplenism is enhanced phagocytosis. This enhanced phagocytosis is due to the immune hypertrophy and is seen in different chronic infections. And this increased phagocytosis is maybe due to upregulation of different cytokines, and these cytokines are the monocyte colony stimulating factors, the tumor necrosis factor beta, interferons, and the interleukin, in different interleukins, which ultimately convert the monocytes to macrophages, and they also stimulate the homing of the monocytes to the monocytes towards the spleen, and there is increased activation of these macrophages, which causes the enhanced phagocytosis of the red cells, causing of the different blood cells, causing cytopenias. Gene dysregulation has also been implicated in different aspects of hypersplenism, where the activation of different genes like the S-phase kinase, the NF-kappa B, and the mTOR pathways. There are also there's also literature on the increased activation of the mRNAs, which are responsible for coding the different pattern recognition receptors and toll-like receptors on the macrophages, which ultimately causes the increased macrophage activation and enhanced phagocytosis. The clinical lab features. The clinical features will be splenomegaly. There will be early satiety, sagging pain, and there will be shoulder pain due to irritation of the phrenic nerves. And the laboratory features, there will be on the hematology aspect, there will be cytopenias. The cytopenias is usually moderate and usually compensated, but there can be significant cytopenias which may require definitive treatment, and even splenectomy may also be required in certain cases. So just to describe some diseases, although I will not be able to go through all the diseases. So some of the diseases I will try to cover. The hereditary hemolytic anemias, they are associated with hypersplenism mainly due to inherent defect in the red cells itself. So when there is defect in the red cell itself, there will be increased destruction of these red cells in the spleen, and there will be cytopenias. So cytopenias, and there will be anemias. So in hereditary spherocytosis, there is mainly a defect in the membrane proteins. These membrane proteins are mainly ankyrin, spectrin, or band 3 proteins, or the protein 4.2. So what happens is that these cells, when they are formed, so during formation, these cells are normally biconcave in shape, but certain parts of the cells, they will uh, sorry. So certain parts of this membrane, they are unsupported by this ankyrin and spectrin, and as they pass through the spleen, these unsupported membranes, they are taken off and knocked off by the spleen. And as this cell have multiple passes through the splenic microcirculation, so what will happen? These cells will increasingly lose some of their membranes which are unsupported, and will acquire a spherical shape. So for a particular volume, the surface area will decrease. As these cells, they acquire a spherical shape, they will be unable to pass through the fenestrated venous sinuses, and they will be trapped in this splenic reticulum of this splenic cords, and they will be destroyed. So there will be increased extravascular hemolysis. And the clinical features will be hemolytic anemia with jaundice and splenomegaly. The treatment will be splenectomy in severe cases, although in most of the cases there can be mild to moderate anemias which can be compensated. And other defects are the hereditary erythrocytosis or the ovalocytosis, and the different enzyme defects. Enzyme defects like the G6P deficiency or the pyruvate kinase deficiencies. In hereditary hemolytic anemias, thalassemia is a very important cause where there is hypersplenism. This hypersplenism is also mainly due to reduced low chain synthesis. So this um, hypersplenism is secondary to this inherent defects in the red cell, in the production of this red cell components. There is reduced low chain synthesis. The in the alpha thalassemias there is usually gene deletion, whereas in beta thalassemia and there is point mutation. So what happens is that in beta thalassemias, usually which present as beta thalassemia major, which are more important to discuss here, the pathophysiology is there is excess of alpha chains which are deposited and which form clumps, and these alpha chains, this excess of alpha chains, they are precipitated, and they call cell membrane damage. So this cell membrane damage, they cause the premature destruction of the erythroid precursors in the bone marrow, and there is ineffective erythropoiesis. There is also increased these alpha chains form red cell inclusions in the red cells, and they undergo increased hemolysis in the spleen, and due to this ineffective erythropoiesis and the increased hemolysis, there is ultimately anemia in beta thalassemia major. So, to compensate for this anemia, there is extramedullary hematopoiesis, and due to increased erythropoietin drive, and ultimately there is splenomegaly. There is massive splenomegaly, and there can be and this massive splenomegaly will cause the hypersplenism by increased trapping of these red cells. So the clinical features will be anemia. There will be hepatosplenomegaly, as I said. There will be bone changes mainly, and there will be increased susceptibility to infections. The treatment will be blood transfusion, because this blood transfusion this shuts off the erythropoietin drive and will prevent the extramedullary hematopoiesis, which will decrease the spleen size. And with blood transfusion, the iron chelation is very important. Splenectomy in the thalassemia, beta thalassemia major, is a relative indication. It's not an absolute indication. It should be considered if there is massive splenomegaly, and if there is worsening anemia resulting in growth failure, if there is massive splenomegaly with impending chances of rupture, or there is hypersplenism causing cytopenias. Only in those conditions, a splenectomy should be considered, because once splenectomy is done, the child will be more susceptible to infections. So, splenectomy should be considered in certain cases where the anemia is not being, there is a refractory anemia which is not responding to treatment. And in immune hemolytic anemia, just an overview, in immune hemolytic anemia, it can be warm type or cold type. This warm type immune hemolytic anemia are mainly due to IgG antibodies and complement, where there is extravascular hemolysis due to destruction in the in the spleen. And the cold type cold type immune hemolytic anemia, they are, because they are there is mainly intravascular hemolysis rather than extravascular hemolysis, as the IgM molecules, they disperse away when when they flow through the central system of the body, where the temperature is more than 30 degrees. And the clinical feature is usually anemia, jaundice, and splenomegaly is seen in around 50% cases. So this the splenomegaly seen in immune hemolytic anemia is mainly due to the warm antibody type of hemolytic anemia, due to hyperfunctioning of the splenic macrophages, due to IgG and uh, complement being bound to the antibodies, they our complement being bound to the red cells and increased destruction in the spleen. So the treatment in immune hemolytic anemia should also be to treat the cause. High dose of steroids should be used. There is also role of monoclonal antibodies uh, nowadays, and splenectomy should be done if therapy fails, and it's required mainly in the one type of immune hemolytic anemia, and rarely still splenectomy should be the last retort, and usually is not required in most of the cases. In immune thrombocytopenic purpura, thrombotic thrombocytopenic purpura, there can be splenomegaly. Although in ITPs, this splenomegaly is not often seen. The spleen can be of normal size, but there is hyperfunctioning of the spleen as there is IgG antibodies formed against the platelet glycoproteins, which coat this the different glycoproteins. These IgGs are mainly targeted against and the glycoproteins GP2B3A or GP1B9. These IgG coated platelets, when they enter into the splenic circulation, the macrophages they have the FC receptors against the immunoglobulins. They identify these coated platelets and they destroy these platelets. So there is macrophage activation also in these cases due to increased coating of the immunoglobulins to the IgG to the platelet, and there is destruction of the of the platelets causing thrombocytopenia. So there is purpura bleeding manifestations. The treatment is mainly steroids and high dose of IVIGs, monoclonal antibodies, and different immunosuppressants like vincristines or danazol or azathioprine. They are also used. And splenectomy, usually it's not required, but splenectomy may be considered if all these treatments they fail. And it should be remembered that splenectomy should be avoided wherever possible in ITPs. And most of the chronic ITPs, they usually respond to these conventional therapies. So in TTP, there is deficiency of ADAMTS 13 metalloproteases, and there is microangiopathic type of hemolytic anemia. TTPs can be due to can be due to acquired or a hereditary form where is a genetic defect in ADAMTS 13, or there is acquired antibodies against this ADAMTS 13 molecules. So usually treatment is plasmapheresis using FFPs. Splenectomy is rarely done. And now moving on to the congestive disorders like cirrhosis and portal hypertension. So what happens in cirrhosis, the main mechanism for this hypersplenism and the splenomegaly is mainly congestive. So due to portal hypertension in cirrhosis, there is outflow obstruction and there is congestion in the spleen causing splenomegaly and the pooling of the red cells, pooling of the blood elements in the spleen causing hypersplenism. So here also the hypersplenism is secondary to cirrhosis and portal hypertension. The mechanism, as I had said, it is congestive cause of hypersplenism, but recent data and also there are studies which have speculated that this hypersplenism in cirrhosis or in liver disease is not a passive not a passive process. It is not secondary to congestion, but it is rather an active process in which there is altered hemodynamics and there is tissue injury in form of liver disease. And this tissue injury, there is causes increased in inflammation and cytokine release. This cytokine release causes the differential activation of the macrophages and the CD4 plus T cells. These cytokines also promote the transformation of the monocytes to the macrophages in the spleen. These macrophages they engulf more and more RBCs, and this hyperactivation of the macrophages often leads to the cytopenias. So in cirrhosis and portal hypertension, although the main mechanism is congestive, there can be there can be increased cytokine release and inflammation secondary to the tissue injury, that is the liver injury, and increased activation of macrophages, which may cause this hypersplenism. Hypersplenism in relation to infiltrative diseases can be in different malignant diseases or the non-malignant diseases. The malignant diseases like maybe the lymphomas, the myeloproliferative disease like CML, different histocytosis, whereas the non-malignant diseases are mainly the storage disorders like Gaucher or Niemann-Pick diseases. And in sarcoidosis, where there is formation of diffuse infiltration by histiocytes forming granulomas. It can lead to massive splenomegaly. And the main mechanism of hypersplenism in these infiltrative disorders is the widening of the splenic cords by the infiltration of the macrophages or the tumor cells. So, as there is widening of the splenic cords, the normal red cells, they will be trapped. The normal blood elements will be trapped, which will cause peripheral cytopenias. And it should also be borne in mind that in these infiltrative diseases, the cause of cytopenias is not always due to the widening of the splenic cord or the splenic cause. It can also be due to infiltration by these cells. For example, the infiltration of storage cells into the bone marrow, or in different lymphomas or myeloproliferative disorders, there is bone marrow infiltration cause there is increased production of this hematopoietic cells, and the infiltration of the storage cells, which can ultimately decrease the erythropoiesis, and they decrease the hematopoiesis and can cause cytopenias. So, this clinic aspect of cytopenias in infiltrative diseases is due to mainly the widening of the splenic cords with trapping of the normal blood elements. So, splenectomy in infiltrative diseases like Gaucher's should only be considered if there is massive splenomegaly and there is increased risk of rupture. Infections, hypersplenism can also be seen in different chronic infections or chronic inflammatory disorders. The chronic infections, among this chronic infection, there is a condition called tropical splenomegaly syndrome, in which the recurrent infections with malaria in endemic zones causes increased activation of the macrophages, and there is massive splenomegaly, causing entrapment of the cellular elements of the blood elements in the spleen, causing cytopenias. And in tropical splenomegaly syndrome, usually IgM is raised and the malarial antibody is positive, although there are no constitutional symptoms or parasitemia. And usually the treatment is antimalarials like chloroquine or Proguan. Chronic hepatitis B and chronic hepatitis C, they may cause portal hypertension and can cause splenomegaly and hypersplenism by congestive mechanism, in which there is outflow obstruction. Schistosomiasis can cause portal obstruction. And there are also some reports that certain fungal infection can also lead to splenomegaly and hypersplenism. Non-cirrhotic portal fibrosis, it is also known as idiopathic portal hypertension or pre-sinusoidal portal hypertension. Usually the onset is in second to third decade. The cases of non-cirrhotic portal fibrosis can be associated with cytopenias, mainly due to idiopathic portal hypertension. There is a recurrent bacterial infection, and it may be due to chronic arsenic use or due to post chemotherapy like methotrexate or azathioprine. Liver biopsy will only show periportal fibrosis. There will be no cirrhosis, and hypersplenism is seen in about 60 to 90% of the cases of non-cirrhotic portal fibrosis, and splenomegaly is universally present in all cases of NCPF. Treatment is usually conservative or different surgeries. Some other rare causes of hypersplenism are mainly due to immune hyperplasia of the spleen, as seen in Felty syndrome, which is nothing but a triad of rheumatoid arthritis, splenomegaly, and neutropenia. Hypersplenism can also be seen in myelofibrosis due to primary, which can be primary or secondary, due to other different diseases. There is usually variable cytopenias. And a rare cause of hypersplenism which deserves mention is the acute hypersplenism, which is seen in sickle cell anemia. So what happens in children, in patients with sickle cell disease in very early phase, within 3 months to, it mainly manifests in 3 months to 2 years of age. So there is a rapid sequestration crisis in which the sickle cells, the cells, when this the sickle cells, the cells which contain the abnormal sickle type of hemoglobin, they when they enter into the spleen, they undergo oxidative stress and they are rapidly sickle. And this sickle causes rapid sequestration and entrampment into the uh, spleen, causing a sequestration crisis with rapid increase in spleen size and a rapid hemoglobin drop of more than 2 gram per dl, causing hypovolemic shock. So this is most common in the early ages, within 6 months to 5 years of age, and more than 75% cases occurs less than 2 years of age. The treatment, it should be treated as a medical emergency by oxygen fluids and it's a transfusion. So this acute hypersplenism, which is seen in sickle cell anemia, that should be kept in mind when there is acute sequestration crisis in a child. And splenectomy, if there are repeated recurrences of this rapid sequestration crisis, it should be considered. There are also reports of hypersplenism associated with associated and in relation to stem cell transplantation. There are some papers and some literature where the effects of spleen status on early outcomes uh, have been assayed after hematopoietic stem cell transplantation, and it has been seen that the patients who undergo hematopoietic stem cell transplantation, the patients with who have splenomegaly, usually there is delayed stem cell engraftment and more chances of graft versus host disease. And this is mainly due to the increased activity of the spleen due to activation of the macrophages. Uh, and also there is one article where the enlarged spleen is associated with a low neutrophil and platelet engraftment rates, and there is poor survival after the stem cell transplantation. This is mainly due to the hyperactive spleen and the hyperactivation of the macrophages, which causes delay in engraftment. So hypersplenism, as I had said, it can occur in different conditions, and it is usually secondary. It is very rarely primary in less than 10% of the cases. So, for a workup of hypersplenism, first the primary thing should be the workup for the etiology. So, as 90 more than 90% of the cases are secondary, we have to do a etiological workup to find out whether we can find any primary cause. So at first we have to do a USG and a LFT, and we have to do different coagulation tests to see whether there is any portal hypertension. The liver cause has to be excluded first. So if there is portal hypertension, the hypersplenism is mainly congestive and it can be due to cirrhosis or it can be due to thrombosis of the portal of the portal vein or the splenic vein or the hepatic vein. If there is systemic or constitutional symptoms associated with cytopenias and splenomegaly, so we have to look for infections. We have to exclude whether there is any infiltrative disease, or we have to look for immune diseases like the different types of autoimmune diseases like rheumatoid arthritis or SLE. And infiltrative disease, we can do workup for to exclude if there is any malignant disease or a non-malignant disease. These storage diseases usually are the non-malignant infiltrative causes of hypersplenism, and the malignant diseases may be lymphomas, leukemias, and myeloproliferative neoplasms. Apart from this, if there are blood smear abnormalities upfront, for example, if there are increased number of nucleated RBCs, or there are increased number of fragmented cells or target cells or teardrop cells, so in diseases, we have to, if there are blood smear abnormalities, we have to exclude the hematological diseases like the thalassemia, spherocytosis, and sickle cell diseases, and we have to do relevant investigations to find out the cause of hypersplenism. So management of hypersplenism, first we have to ascertain whether there is true hypersplenism. So in most of the cases, as the hypersplenism is secondary to some primary disease, so we should first treat the etiology. If there is infection, medical management should be done. Relevant the drugs should be used. Some antibiotics should be used to treat the infections. If there is portal hypertension, the shunts can be treatment of choice. In liver diseases, medical management of the underlying liver disease should be done. In case of storage diseases, the medical management should be enzyme replacement therapy, although it is not feasible and not available everywhere. If there is extramedullary hematopoiesis, then we have to treat the ineffective we have to treat the ineffective hematopoiesis by blood transfusion and all. And we have to also ascertain whether we are truly dealing with the hypersplenism, or the hypersplenism is secondary to some other causes of cytopenias, like a bone marrow suppression. For example, if there is a bone marrow suppression, so that can be excluded by a bone marrow study, where we will find, if we find a normal or cellular marrow and peripheral cytopenia, we have to then it is hypersplenism. If there is a bone marrow suppression, hypoplastic marrow, then it is possibly due to the cytopenia is not due to the spleen, it's due to some other cause. Drug history should also be taken into account, because there are certain drugs which can cause bone marrow suppression and hence can cause peripheral cytopenias. And also we have to evaluate the primary etiologies. So then after evaluation of the primary etiology, we have to assess the severity of hypersplenism. So if usually in most cases the hypersplenism associated causing cytopenias is usually moderate, and it's usually asymptomatic. In these cases conservative treatment of the cause should be done. If there is symptomatic hypersplenism causing severe cytopenia or cytopenias, then conservative management should be first. Conservative management should be used with supportive therapy, and the basis should or the treatment should always be focused on to avoid splenectomy. And if at all there is symptoms persisting, or there is refractory cytopenias, and clinical and laboratory assessment should be done in all cases to see whether this hypersplenism is mainly due to the hyperactive spleen. So in those cases, the splenectomy should be done along with vaccination, which is mandatory in all splenectomized patients. So splenectomy, it should be deferred until 5 to 6 years of age, because in early childhood there is increased risk of different types of infections, more due to the encapsulated organisms, because the immune system and the immune setup of the body is not yet complete, and the immune setup is not yet developed like adults. So it should be deferred to prevent the life-threatening infections. The indications should be weighted, whether it should be considered whether there are absolute indications or the indications are relative. So absolute indications are the traumatic rupture of the spleen, or the splenic tumors and the cysts which are interfering with the functions. All the rest of the indications are relative. For example, in transfusion-dependent hemolytic anemias and thalassemias, the primary objective should be to prevent splenectomy, and the ineffective erythropoiesis should be, and the extramedullary hematopoiesis should be counteracted by repeated blood transfusions. And proper blood transfusion can ameliorate and prevent splenectomy at an early age. In hereditary spherocytosis, if the anemia is mild to moderate, usually splenectomy is not required. But if there is severe worsening anemia, splenectomy may be considered. In immune thrombocytopenias, usually splenectomy is not done, and the conservative treatment with steroids or intravenous immunoglobulins are mostly effective in controlling ITPs. In storage disorders, if there is massive splenomegaly with hypersplenism and associated cytopenias, splenectomy may be considered. And in other causes of secondary hypersplenism, the underlying primary etiology should be evaluated, and the splenectomy should be considered likewise. So complications of splenectomy, the complications are maybe immediate, that is surgery related. It can be bleeding due to surgery related complications. It can be pancreatic complications, as during splenectomy there can be injury to pancreas causing pancreatitis. There can be abscess or pseudocyst formation. There can be post-operative thrombocytosis. Now, as I had said, that spleen is a reservoir of platelet. About 30 to 40% of the normal platelet pool is stored in the spleen. So when there is when we perform the splenectomy, there can be immediate post-operative thrombocytosis, and the platelet counts can raise up to 15 lakh per cubic millimeter. So in these cases, the use of aspirin treatment has been said to be of some value, although it is not used routinely. And thrombosis and embolism. Portal venous thrombosis can also occur can also occur as an immediate complication of splenectomy, in which anticoagulant should be used. And there can be lymphocytosis and monocytosis along with thrombocytosis in the patient, which can also persist lifelong. The risk of infection, the early risk of infection or infection with staphylococcus or gram-negative bacilli. But what we are more concerned with is the late complication of infections by different encapsulated organisms. As I had said, that the spleen has a specialized marginal zone, which is rich in the marginal zone B cells, which are the specialized cells for against this encapsulated bacteria. And also the spleen, the marginal zone of the spleen has the specialized macrophages, which are also involved in the innate immunity through different pattern recognition receptors and the toll-like receptors. So when we have done a splenectomy, the individual is susceptible to infections by these encapsulated organisms, which can cause life-threatening infection, which is known as OPSI or the overwhelming post-splenectomy infections. And there can be autotransplantation during splenic surgery, in which some part of the splenic tissue may be left behind which can cause recurrence of the disease for which the spleen has been operated. Now, a word on overwhelming post-splenectomy infections. It is inversely related to age. That means it's as the age increases, the chances of OPSI decreases. So this is the reason why this splenectomy should be delayed at least up to 5 years of age. These post-splenectomy infections are mainly due to infections by the Streptococcus pneumoniae, Neisseria meningitis, and the Haemophilus influenzae bacteria, which are all encapsulated organisms. And after a spleen is removed, the protective function of the body against this encapsulated organism is lost. So there is increased susceptibility to these organisms. Although these infections may also be caused by other organisms like the E. coli, staph, or streptococcus. Now, the pathophysiology, as I had said, it is mainly due to depletion of the IgM memory B cells present in the marginal zone, and there is compromised humoral immunity due to depletion of the cells, and also there is absence of the innate immune system of the innate immunity conferred by the specialized macrophages present in the splenic marginal zone. So there is also inadequate complement factors, that is decreased depleted levels of propardin, tufsin, or factor B, because the spleen is involved in the production of this complement factors. And the clinical features of this condition is there will be fever, and there will be it may start with fever or upper respiratory tract infection, and it can quickly develop into sepsis, shock with DIC, and organ failures. And there can be deaths as high as in 50 to 90% of the cases. So identification of these infections is important, and to prevent this overwhelming infections, the triad of vaccination, proper patient education, and antibiotic prophylaxis should be considered in all splenectomy patients. Now, vaccination, just overview, as the individuals are more susceptible to infection by these three types of organisms: the pneumococcal infections, the Haemophilus, and the meningococcal infection. So, vaccination against pneumococcus, that can be a pneumococcal polysaccharide vaccine 23, that is PPV 23, or the conjugated vaccine 13, and along with combined Haemophilus meningococcal conjugate vaccine, that should be given at least 2 weeks prior to splenectomy to to mount an immune response against these organisms by the spleen. And after 2 weeks, splenectomy should be done. Revaccination after 5 years by pneumococcal vaccine should be considered, although some clinicians, they prefer to see pneumococcal antibody levels before considering revaccination. And all these patients should also be given influenza vaccines, because influenza virus makes infection with influenza uh, is usually associated with secondary bacterial infections. So annual vaccination by this, annual vaccination of influenza should be given to all individuals. In children less than 2 years, there should be complete vaccination should be given along with Haemophilus and meningococcal conjugate and PCV 13 at uh, month 0, and later after the second birthday, Haemophilus and meningococcal vaccine along with PPV 23 should be considered. In children who are 2 to 5 years with incomplete vaccination, the first dose of pneumococcal conjugate vaccine 13 along with Haemophilus meningococcal conjugate vaccine should be given, along with uh, pneumococcal conjugate vaccine 13 second dose at after 2 months, and pneumococcal polysaccharide vaccine should also be given. And the children below 2 years, 2 to 5 years, with complete vaccination should be given booster of Haemophilus meningococcal vaccine along with pneumococcal polysaccharide vaccine 23, and revaccination should be done for this polysaccharide vaccine to 23. Quadrivalent vaccine of ACWY vaccine against meningococcus and Haemophilus may be considered at 1 month after surgery, although this is variable. Antibiotic prophylaxis should be given to all these patients undergoing splenectomy. Penicillin or erythromycin may be considered mainly in children in a dose of 250 milligram BD. Preemptive antibiotics, that is an antibiotic prescription of amoxicillin or levofloxacin, should be given to the patient, and the patient should be educated for potential conditions where there may be infections, where the patient can himself start on this preemptive antibiotics before seeking medical attention. And the use of antibiotic prophylaxis, that can be stratified and high risk patients who are less than 16 years of age, or aged patients, or with inadequate serological response or history of prior invasive pneumococcal disease. They should be mandatorily given antibiotic prophylaxis. The patients who do not have these factors should be counseled for the risk of these infections, and should always seek medical attention if there are any episodes of any infection in these individuals. So, as we have discussed splenectomy, now let's move on to hyposplenism. So, splenectomy is most important cause for asplenia, that is lack of a spleen. So, first the definitions. What is asplenia? Asplenia means there is lack of a spleen. So, this lack of a spleen may be congenital. In complex congenital heart diseases or dextrocardia, a spleen may be completely absent. So that is a congenital cause of asplenia, and surgical removal or splenectomy is the cause of asplenia in older individuals or individuals who have undergone spleen removal. Functional asplenia is due to complete loss of splenic function. In the functional asplenia, the spleen may be present, but there will be complete loss of splenic function, and it can be seen in sickle cell diseases, sickle cell anemia mainly, in which there are uh, repeated infarctions, and infarctions causes atrophy of the spleen, and there can be presence of spleen, but there will be complete loss of splenic function. And hyposplenism means a partial loss of splenic function, in which the underlying diseases, they cause decreased function of the spleen. So this is functional hyposplenism. So causes of hyposplenism: different hematolo-oncological diseases can cause hyposplenism, of which sickle cell disease is the most important cause of hyposplenism. In the previous section of hypersplenism, I had described how acute sequestration crisis of the sickle red cells in the spleen can cause hypovolemia and rapid drop in hemoglobin, causing sequestration crisis and uh, splenomegaly with hypersplenism. But in most cases of sickle cell anemia, there is usually repeated infarcts due to obstruction by the sickle cell in the splenic vasculature, causing splenic atrophy, and finally there can be autosplenectomy. So sickle cell anemia and sickle cell disease is a very important cause of hyposplenism and asplenia. Leukemias, lymphomas, usually in the early phase, they can present with hypersplenism because they increase the splenic reticulum, and they can cause cytopenias. But in late form of the disease, where there is diffuse infiltration of the spleen by the leukemic cells or the lymphomas infiltration, there will be disruption of the normal splenic architecture, and there will be decreased function of the spleen, causing hyposplenism. Hepatic disorders, portal hypertension and cirrhosis. Usually there is hypersplenism, but it can also cause hyposplenism, because in portal hypertension and cirrhosis, there is increased chances of infections, and as I had said, that there is there are different active mechanisms in cirrhosis and portal hypertension, where there is increased macrophage activation. There can be reticuloendothelial the reticuloendothelial block, in which the over functioning of this splenic white pulp can often lead to dampened responses to different infections, and increases chances of infections, and may cause hyposplenism. Alcoholic liver disease and autoimmune hepatitis, they can cause hyposplenism. Alcohol, it has been postulated that alcohol has direct toxic injuries to the splenic macrophages, and also the acetaldehyde adducts, which are formed in chronic alcoholic patients. They are engulfed by the macrophages, causing saturation of these splenic macrophages, causing hyposplenism and decreased protective function of the spleen. In autoimmune hepatitis, there are formation of antigen antibody complexes, which are then taken up by the splenic macrophages, and they can cause a reticuloendothelial block, and hence cause hyposplenism. Different autoimmune diseases, they can cause hyposplenism by increased formation of antigen antibody complexes, which are then taken up by the spleen, and there can be depletion of the effective immune cells, mainly the macrophages, and can cause hyposplenism. GI disease disorders, I will discuss in detail. It is an important cause of hyposplenism, but celiac diseases and IBDs, mainly ulcerative colitis, are associated with hyposplenism through three different mechanisms. Infections can also cause hyposplenism. Circulatory disorders like splenic or celiac artery thrombosis can cause decreased blood flow to the spleen, and ultimately cause splenic atrophy and cause hyposplenism. Miscellaneous diseases, sarcoidosis, usually in the early phases of disease, there is hypersplenism due to increased expansion of the splenic reticulum cells with trapping of these blood cells. But in later form of the diseases, where there is diffuse infiltration of the spleen by the histiocytes and granulomas, there will be changes in this clinic normal architecture, and this will cause the decreased functioning of this spleen. Amyloidosis is an important cause of splenomegaly and hyposplenism. In amyloidosis, there is extracellular deposition of amyloid in the splenic parenchyma. This extracellular amyloid deposition will cause a massive splenomegaly and will also cause hepatomegaly. But as this deposition is there in the extracellular component, it will result in atrophy of the splenic red pulp and the white pulp, and ultimately cause hyposplenism. Different radiations and steroid therapy. The radiations can cause hyposplenism by causing the damage to the splenic parenchyma, and steroid therapy causes hyposplenism by inhibiting the neutrophils and the macrophages and decreasing the splenic function, causing hyposplenism. So, what are the results of hyposplenism? The first important result of hyposplenism will be dysfunction of the immune homeostasis. So, as I had said, that the spleen is involved in the immune and protective function. So, in hyposplenism, there will be decreased function of the macrophages and the different lymphocytes, and there will be increased susceptibility to infections. There will be increased risk of vascular events like thrombosis and embolism. Why? Because of two causes. Firstly, as I had said, that the spleen is the reservoir of different drug components, namely mainly the platelets, and one third of the platelets are stored in the spleen. So when there will be hyposplenism, or there can be there can be aspenia due to splenectomy, there will be increased migration of this thrombocytes and increased flow of these platelets into the circulation. This increased platelets into the circulation will predispose the patient to increased vascular events, and also in different if there is underlying hemolytic diseases, this and splenectomy has been done, so the damaged red cells, they will go into the circulation, and they will cause ultimately blockade in the different in the microvasculature, causing activation of the platelets and ultimately causing thrombosis. The senescent RBCs and the aged RBCs, as I had said, that they are normally removed by the spleen and by the splenic macrophages, but in cases of hyposplenism, so these damaged senescent RBCs, they will enter into the circulation, and they will call these damaged RBCs. They will cause they will be trapped in the different different areas of microcirculation, and uh, by activation of the platelets, they will cause different thrombotic events. The derangement of the filtration function, although this is not a result of although this is not a not of clinical importance, still the dysfunctional RBCs or the red cell inclusions will be present in the circulation, and which will be picked up during routine microscopy. And the manifestation of hyposplenism, so that will depend on the severity of this of the decrease in splenic function. In asthenia, or due to autosplenectomy in sickle cell disease, or in after surgical removal, there will be massive bacteremia by encapsulated organisms, although the chances of this massive bacteremia is less in patients in which the splenic function is mildly decreased. There will be no obvious the patients with marked hyposplenism will be susceptible to massive bacteremia. As I said, there will be no obvious primary source of infection, and after a short non-specific prodromal phase, these patients can quickly move on to quickly deteriorate to septic shock or DIC, and there will also be chances of bilateral adrenal hemorrhage or the Waterhouse Fredrickson syndrome due to meningococcemia. And this degree, the factors which will the factors which will mainly dictate whether the manifestations of this hyposplenism will be mild or will be severe. It will be on the degree or severity of the loss of splenic function. It will depend on the underlying etiology and also the age at which a spleen is removed. Children less than 5 years of age, they will be more susceptible to this type of massive bacteremia and infection by encapsulated organisms, whereas adults, they will usually have a milder diseases. So hematological changes in hyposplenism and after splenectomies, the RBCs, we will find these different bodies, different inclusions in the red cells. The Howell-Jolly bodies, they are the nuclear remnants present in the RBCs. It will be found in most cases, and in most individuals, in Howell-Jolly bodies will be detected. Heinz bodies are the hemoglobin, the denatured hemoglobin fragments, which will be found in the dead cells. Pappenheimer bodies, they are the siderotic granules which will be present in the dead cells. Acanthocyte or the spiculated cells will be numerous, and the target cells will be present in the peripheral smears, and all the presence of all these bodies, that will as I had said, will depend on the degree of the hyposplenism that is present. The MCV hemoglobin is usually normal. WBCs, there will be increased total counts in splenectomized patients. There will be the counts may be increased up to 15,000, 10 to 15,000, and in patients with milder forms of hyposplenism, the counts may even be normal. Lymphocytes usually raised in more than 40% of the cases, and lymphocytes will be raised. The differential count of lymphocytes will be more than 40% per percent, and also there can be increase in monocyte and eosinophil differential count. Usually it is moderate, and the differential count of monocytes and eosinophil may be as high as 20%. Basophils may also be raised in the peripheral circulation, but usually the differential count is less than 3%. Platelets, post-operatively, in post-splenectomy patients, the platelets may be markedly increased. It may be more than 15 lakhs in the immediate post-operative period, for which treatment by aspirin or by anticoagulants may be considered. Whereas in long-term cases, mainly splenectomized patients, there will be persistent increase in platelet count, and in up to 40 to 50% of the cases, platelet count will be persistently more than 4 lakhs. So this is a peripheral, the different red cell inclusions which are usually found in hyposplenism and the splenectomized patients. These are the nuclear remnants, which are the Howell-Jolly bodies, which can be picked up in normal Leishman stain smears. These are the denatured hemoglobin particles or fragments, which are the Heinz bodies. They are usually not, they cannot be identified in routine blood smears stained by Leishman stain, and supravital stains like new methylene blue is required for identification of these Heinz bodies. Pappenheimer bodies, these are the sedative granules which are more granular. These are the sedative granules which are also found in red cells, and there will be increased number of the spiculated cells or the acanthocytes, which are normally removed by the spleen, but they escape into the peripheral circulation in cases of hyposplenism, and definitely in cases of splenectomized patients. So, hyposplenism in sickle cell disease, it has to be discussed in detail. In sickle cell disease, these cells, they are normally biconcave in shape, but when they pass through the spleen, they are subjected to oxidative stress, and during this oxidative stress, these sickle cells, they get denatured, and they uh, bind to one another, forming these classical HBS polymers. So this increase this sickle cells, they get trapped into the venous sinusoids, and they can cause this sequestration, different types of crisis. The sequestration crisis, which I had discussed in the hypersplenism segment, it is an acute crisis which occurs due to this sequestration and the and acute trapping of this sickle red cells within the spleen, causing rapid enlargement in the size of the spleen with rapid entrapment of the blood elements, causing acute hypovolemia and shock. The vaso-occlusive crisis is due to the entrapment of the sickle cells uh, into the vasculature, and into the splenic, this entrapment of this different sickle cells in the spleen will cause infarction, and over multiple over long term, the spleen will ultimately undergo atrophy and will be smaller in size, and ultimately will undergo autosplenectomy, uh, where the majority of the splenic function is lost. And the other crises are the hemolytic crisis. The hemolytic crises are mainly due to the increased hemolysis of the red cells, and the aplastic crisis, where there is a associated bone marrow suppression due to associated infection, mainly by parvovirus B19 viruses. So in sickle cell disease, there can be hypersplenism followed by hyposplenism, and the mechanism of this hyposplenism in sickle cell disease is mainly due to diversion shunts. As I had said, there is infarction of the splenic vasculature, and there will be formation of different shunts, and there will be reticuloendothelial block. The reticuloendothelial block will be there because there will be increased trapping of the sickle cells in the spleen, and this increased number of sickle cells, they will be entrapped. They will be entrapped in the splenic cords of the reticulum, the cords, and the macrophages. These macrophages will engulf more and more sickle cells, and ultimately these macrophages will be saturated with sickle cells, and there will be features of hyposplenism, and there will ultimately there will be decrease in splenic function, and there will be decreased production of the staphylococcus and propardin by the spleen, which can lead to different infections in sickle cell disease. So these are the mechanism of hyposplenism in sickle cell disease. So hyposplenism in GI and liver disorders. This is also well studied, and numerous articles are available on the presence of hyposplenism in different GI disorders, mainly the celiac disease and inflammatory bowel diseases. So hyposplenism can be seen in different hepatic disorders, as I said, in autoimmune liver diseases, the primary biliary cholangitis, alcoholic liver diseases. Celiac disease is associated with consistent forms of hyposplenism, and Crohn's disease, tropical sprue or Whipple's disease can also cause hyposplenism. Autoimmune gastritis and eosinophilic esophagitis is also speculated to cause hyposplenism, and IBD is also associated with hyposplenism. So, basic mechanism behind hyposplenism in these GI disorders is due to three causes. The first cause is the reticuloendothelial blockade. The reticuloendothelial blockade is due to increased circulating and antigen antibody complexes in celiac disease and celiac disease. So there will be increased activity of the macrophages, and these macrophages will engulf more and more antigen antibody complexes, causing saturation and depletion of this macrophage pool of the skin, and so there will be increased risk of infections, and there will be hyposplenism. The other cause of reticuloendothelial blockade is because in celiac disease and inflammatory bowel diseases, the main barrier immunity that is the gut-related barrier to the different gut-related pathogens is lost. So more and more pathogens, they enter into the blood circulation and they ultimately reach the spleen. There is increased macrophage activation, and these macrophages, there will be increased function of the macrophages, and these macrophages will be more involved in counteracting these gut-borne pathogens, which come to the spleen, which normally do not occur if there is an intact barrier immunity of the gut. So this is another form of reticuloendothelial blockade which will cause this hyposplenism. The other cause of hyposplenism is reticuloendothelial atrophy, which is caused due to increased lymphocyte egress egress and failure of the splenic lymphocyte recirculation. So what happens is that in celiac disease, in the histology, we have seen that in celiac disease there is increased number of intraepithelial lymphocytes, and there will be there will be variable amount of villus blunting and crypt hyperplasia. And as there is increased number of intraepithelial lymphocytes, it has been postulated that there is increased migration of these lymphocytes from the spleen into the gut, where more and more migration of the lymphocytes ultimately causes atrophy of the reticuloendothelial white pulp of the spleen, and this causes the hyposplenism associated with different GI diseases, mainly celiac diseases. In inflammatory bowel disease also, there is increased number of immune complexes, as it has been thought that there is increased number of immune complex formation in IBDs, mainly ulcerative colitis, causing reticuloendothelial blockade. And the third mechanism is splenic atrophy. So the main pathogenesis behind splenic atrophy is not known, although the possible autoimmune phenomenon is mainly the autoimmune phenomenon is likely to be present, which leads to loss of specific splenic regions. Mesenteric lymph node cavitation is another entity which is associated with hyposplenism and is seen in cases of hyposplenism associated with celiac diseases, in which there will be cavitations formed in the intra-abdominal and mesenteric lymph nodes, and it is also thought to be due to an autoimmune phenomenon leading to loss of lymph nodal regions. In chronic alcoholism, it has been speculated that the hyposplenism is mainly due to the direct toxic effect of the on the macrophages. The acetaldehyde adducts, which are derived from the alcohol, increased consumption of alcohol, form immune complexes, and they saturate the splenic macrophages, and associated nutritional deficiency also causes this hyposplenism. Other diseases associated with hyposplenism I have already mentioned in the causes: increased circulating immune complexes causing reticuloendothelial block in the different autoimmune diseases. Leukemia, lymphomas, sarcomas, they can cause hyposplenism in the later stages, where diffuse infiltration of the spleen by these malignancies will cause splenic architecture disruption and decrease normal functioning of the spleen. In HIV, hyposplenism may be due to direct effect of the virus, or due to decreased IgM memory B cells. And in amyloidosis, as I had said, that hyposplenism is due to deposition of this amyloid in the spleen, disrupting the normal splenic architecture and hence splenic function. Steroids can cause hyposplenism by suppressing the macrophage and the phagocytic activity of the neutrophils. Aging is related with also a cause of hyposplenism, in which there is usually atrophy of the splenic compartments as people age, leading to hyposplenism. So there is a review article by Sabatino where they had reviewed this post-splenectomy and different hyposplenic states, and they had mentioned that they had found out that the prevalence of hyposplenism is about 100% of cases with sickle cell anemia, It's usually moderate in cases of bone marrow transplantation or celiac diseases, where around 50% of the cases can have hyposplenism. In alcoholic liver disease or HIV or inflammatory bowel disease, around 30 to 40% cases of 30 to 40% cases have shown hyposplenism. Hyposplenism can also be seen in Whipple's disease or different autoimmune diseases. The degree of hyposplenism will be more marked and severe in cases of sickle cell anemia, because there will be autosplenectomy in the patients of sickle cell anemia. It's usually moderate to severe in other diseases, and usually mild in the Whipple disease and in autoimmune diseases. And so the diseases where there is marked moderate to marked degree of hyposplenism, these patients should be educated on the possibility of overwhelming infections in this, and hence should be given preemptive knowledge of use of antibiotics, and should be advised to take or seek medical attention in cases of infection, any type of infection or fever or something of that. So assessment of hyposplenism. So how to assess hyposplenism? As I had said, in hypersplenism, usually there is associated splenomegaly, but in hyposplenism, it is very difficult to assess whether a patient has a hyposplenism and decreased splenic function. So test may be hematological test or imaging or nuclear scans. So hematological test, Howell-Jolly bodies by routine staining. If there are presence of Howell-Jolly bodies, that should be mentioned in the blood report, and it should it should always alarm the clinician to look for any underlying hyposplenism. So this Howell-Jolly body should be the primary investigation to assess hyposplenism. So, if hyposplenism is suspected in any patient, so the clinician should or should ask the pathologist to look for the Howell-Jolly bodies, and we as pathologists, we should always, while seeing a blood smear, we should be aware of these different RBC inclusions, red cell inclusions, like the Howell-Jolly bodies and the Pappenheimer bodies. So presence of numerous Howell-Jolly bodies, that should make us aware, and that should be reported, and that should be that may be the primary indicator for any underlying hyposplenism. The other hematological test which has been considered to be gold standard in different studies is the finding of pitted erythrocytes. Now, the identification of the pitted erythrocytes is difficult because it is not seen by routine light microscopy, and it requires interference contrast microscopy for identification. So, what are these pitted erythrocytes? Normally, the erythrocytes, as they age, they will show small vesicles under the membrane, under their RBC membrane. So these vesicles are the cellular debris or the denatured hemoglobin, which appear beneath the vesicles, beneath this RBC membrane in form of vesicles. So these vesicles are or the pits are usually removed by the spleen during the splenic circulation by a process called the pitting, which I had discussed in the beginning. So this pitting action of this spleen is lost in cases of hyposplenism. So as this pitting action, pitting function is lost, so these vesicles will remain in the RBCs, and they will coalesce to form small vacuoles or pits. These pits can be picked up while picked up by interference contrast microscopy on a wet preparation of the blood. So more than 4% of pitted erythrocytes is considered to be abnormal and is a important indicator of hyposplenism. And in some studies, it has been said that it is comparable to radioisotope methods in identifying hyposplenism. Imaging and nuclear scans. USG is maybe a primary modality for assessing hyposplenism, because USG can identify the splenic atrophy. Although it is a screening test, atrophic spleens can be picked up by USG, but ultrasonography is usually not a sensitive test for identifying hyposplenism. The other specific nuclear scans are the specific test for hyposplenism, identification of hyposplenism, where technetium level sulfur colloidal scans or heat level or technetium level heat damaged autologous RBC transfusion can be done for assessment of hyposplenism. Now, in technician in sulfur colloidal scan, the quantitation of this splenic uptake of the colloidal sulfur particles is assessed, and the static assessment of the splenic function can identify whether there is any underlying hyposplenism or not. The in the technician level heat damaged autologous RBC transfusion method, the nuclear scan is used to identify the clearance rate of the RBCs. So this measurement of the clearance of the heat damaged RBCs allows the dynamic assessment of the splenic function, and hence the presence of hyposplenism can be picked up by these scans. So, as pathologists, although routinely not done, the identification of the splitted erythrocytes that should be known to us. So, what is done here? A blood sample, it is fixed with 1% buffered formaldehyde in 1:5 ratio at a pH of 7.2. The wet suspension is placed on a slide. Uh, Interference contrast microscopy can be used, or Normansky optics with light microscopy can be used to identify these pits. In this figure, we can see three RBCs with presence of these pits or vacuoles in the red cells. So, presence of these pits in more than 4% of the total circulating RBCs is an indicator or is a determinant for identifying and documenting hyposplenism. So for documentation, it has been advised that 2000 RBC should be counted, although at least 500 RBC should be counted for making a percentage. So hyposplenism, what should be primary approach of approach towards hyposplenism? The first uh, the first indicator of hyposplenism should be the presence of Howell-Jolly bodies if noted in a peripheral blood film. So, if Howell-Jolly bodies are noted, we have to see whether functional hyposplenism or asplenia or asplenia is present or not. So, we can do a primary screening ultrasonogram to see whether the spleen is present or absent. So, spleen may be absent in case of congenital asplenia. If splenectomy has been done, post surgical spleen will be absent. Although from the clinical history itself, we can make out whether splenectomy has been done by taking the history of the patient, and if there is any splenic atrophy, that can also be picked up in a screening ultrasonogram. So, if there is absence of spleen, so we can document that there is asplenia or atrophic hyposplenic state, where we can proceed for where we can proceed as such, and give vaccination to the patient and empirical antibiotic therapy along with patient education. If the hyposplenia or not or asplenia is not there, then we should proceed as for functional hyposplenism. So if spleen is present, but there is presence of Howell-Jolly bodies and increased number of pitted erythrocytes, so there is functional hyposplenism. So in these cases, although it's not available everywhere and it's a cumbersome procedure, the nuclear scan should be done. If there is normal uptake, there is normal splenic function, and the other causes for abnormal RBC structure should be assessed. If there is no uptake by the spleen or decreased uptake by the spleen, there is functional hyposplenism. We have to establish or identify the cause behind this hyposplenism, and If there is a reversible cause, appropriate therapy should be given. If there is irreversible cause, then the triad of patient education, the vaccination, and prophylactic antibiotics should be given. The management of a hyposplenic patient should be in the line of that taken for a splenectomized or asplenic patient. And if there is severe hyposplenism, vaccination may be considered, especially pneumococcal vaccination and influenza vaccination. And in adults, usually hemococcal or meningococcal vaccination, that is optional, but vaccination for pneumococcus and influenza should be must for these hyposplenic patients. Antibiotic prophylaxis that can be given. That also depends on the severity of hyposplenism that is present. Patient education. Now, this is very important in cases of hyposplenic patients. In asplenic patients or splenectomized patients, the patients are already given vaccination or antibiotic prophylaxis. But in cases of hyposplenic patients, the patient should be aware or given awareness that they are at increased susceptibility to different infections, and they should be also taught that they should always notify for any febrile illnesses, and also uh, they should be made aware of the fact that travel to high risk travel to high risk countries like tropical countries can be dangerous for them, and they should be given malarial prophylaxis if they are traveling to tropical countries. Barrier precautions should be taken, that is increased use of different mosquito repellent creams, and all these uh, should be used to prevent any type of infections. And lifelong monitoring should be given to these patients. This patient part of patient education, this is very vital. And hyposplenism, although not very common, it should be borne in mind that patient education is a very important aspect of teaching these patients of how to get themselves aware and be prepared for in case if there are any infections in these patients. So, lastly, the summary: hyper and hyposplenism. These are clinical manifestations of splenic dysfunction. They are not primary diagnosis, and in most of the cases, there is an underlying primary cause which is responsible for this hypersplenic or hyposplenic conditions. Investigation of the primary etiology is very vital. The treatment of the primary cause should be the approach in hyper and hyposplenism. There can be moderate cytopenias in hypersplenism, and the hypersplenism is usually associated with moderate cytopenias. It usually does not require treatment. The spleen should not. Our aim always should be to try to save the spleen as far as possible. Splenectomy can be done if there is massive splenomegaly or if there is worsening cytopenias not responding to therapies. And splenectomy should only be done if it's absolutely required. Identification of hyposplenism is essential because unlike hypersplenism, hyposplenism is missed in most of the cases, and proper assessment of the blood smear and the proper evaluation of the blood smear abnormalities for identification of the different red cell inclusions can be a primary and and first guide for assessment of or identification of hyposplenism. And lastly, in cases of hyposplenism and in patients undergoing splenectomy, vaccination and antibiotic prophylaxis is mandatory, as is patient education. So, thank you. So, this is all about hypersplenism and hyposplenism.
Thank you, Dr. Aniket. A very elaborate, almost 2 hours lecture, and very nicely detailed out I
Thank
agree
you.
with you. I mean, it is very, see, hypersplenism is something which is quite common, large spleens. It's very easy for us to pick it up.
Yes, sir.
And the clinical as well as laboratory indicators are very clear cut and very easy for us to pick up. But for hyposplenism, which can be
Yes.
anatomical or functional,
Or function.
yeah, anatomical and functional, both hyposplenisms are a difficult entity. Picking up Howell Javel bodies, one really need to keep it in mind before seeing
Yes, sir.
peripheral smears. And many a times, many of these Howell Javel bodies may actually be artifacts, which we
Yes.
may overread.
Yes.
So anyway, it was very nice presentation, very detailed, and it will be very useful for everybody to go through this and understand
Thank
what
you, sir.
hyper and hyposplenism is. Thank you, Dr. Aniket. We will
Yeah.
look forward for your next lecture soon.
Yeah.
So
Thank you,
it's a
sir. Thank you.
thank you. Take care. Bye bye.
Yeah, bye.
God bless you. Bye.